Thank you for the introduction. So, as you can see, this work is actually the work of two institutions. One, the Medical University of Vienna, where I come from, and the other is the Technical University of Munich, where Matthias Eiber is the responsible PET-MR person. He cannot be here today, unfortunately. So, when we talk about PET-MR workflow, we have to ask ourselves, why does it even matter? And that's actually quite easily answered. I mean, we all know that the number of PET-MR installation has increased, in particular over the last 5 years. The problem is, when you compare it with PET-CT, the costs clearly exceed those of PET-CT, which in many countries can cause some reimbursement issues, not in the country that I come from, not in Austria, because everything gets reimbursed, sort of, but for instance in Germany there is a different situation. So the patient throughput is also clearly higher for PET-CT. You have your scan in 25 to 30 minutes for the total examination time, 50 patients per day, for instance. In our institution, we cannot manage this in PET-MR. And of course, there is still a discussion ongoing about the killer application for PET-MR. Where does it really provide an advantage compared to PET-CT? And that's why we have to ask ourselves, how can we optimize the PET-MR workflow for maximum efficiency? So, as with all other things in life, there are many different approaches. The three most common I'm going to talk about right now. So the first one is, you could perform PET-MR just using a very, very basic set of sequences. So just enough so you have the attenuation correction and maybe 1 or 2 sequences for anatomical correlation. You could do that, and that would definitely speed up things. But the problem is, why would you buy a PET-MR then? Why not do a PET-CT? If you're worried about radiation exposure, just use low-dose CT and you get basically the same amount of information. But of course, it's one approach. Now the second approach, and that's the one that's favored in most centers that I know, most PET-MR centers, you focus on one region, on one area of interest, for instance, where the primary tumor is located. There you use a full set of diagnostic and functional MR sequences, and for the rest of the body, you just use a basic protocol. And the third approach is to use PET-MR for single region or whole body imaging, and then utilize the remaining time for MR-only examinations. So that would probably also make sense from an economical point of view. So as I mentioned, the two centers that I'm going to talk about today, that's Munich and Vienna. Munich is clearly ahead of us in terms of installation data. We're one of the first centers to have an integrated system installed in 2010. We started at the end of 2013. In terms of applications, we are quite similar number of patients per day. But as indicated by the Bavarian beers and the Viennese coffees here, there are differences, which I'm going to talk about. But we are united by having the same scanner model. So let's first talk about tracers and indications. So on the left side, you have the tracers that we use in Vienna. As you can see, a variety. And on the right, you have the indications. And the ones that are colored in blue are actually the indications where we would prefer PET-MR over PET-CT. So brain tumors, that's what most people would have expected. Lymphoma, I'm focusing on that in terms of research, and also because with DWI you have a very strong parameter in addition to PET. And then the cardiovascular applications, that's also something that most people would expect as an application. Neuroendocrine tumors, of course, we have the DOTA peptide tracers that are extremely specific for this type of tumor. And then, of course, you have MR, which is vastly superior if you use contrast medium in particular, or DWI to CT in the liver, because they normally metastasize into the liver first. Now, prostate cancer, this could probably be one of the killer applications for PET-MR. MR is extremely strong in this department, and PET with the PSMA tracers that are now becoming popular has a highly, highly sensitive and specific way of assessing this cancer. and the gynecological cancers as well as multiple myeloma. So we go to Munich. What are the differences? Actually, not too many. Not that much focus on lymphoma. It's still there in the indications, but not that much focus on it. Prostate is a major focus there. They were one of the first centers to do it. But apart from that, actually, we agree on the indications more or less. So what does the workflow in Vienna look like? So our operating hours are from 8 to 7. We agreed when we got the system that we would try to limit the scanning time to about 1 hour. We can actually go lower in some patients depending on the indication. In lymphoma, for instance, we can go lower. If we use, for instance, a second tracer, then we will exceed the 1 hour and need additional 10, 15 minutes or even 20 minutes. And we also agreed to limit the time per slot to 80 to 90 minutes. So here you can see what a normal day in PET-MR would look like for us. You can also see that we are not just doing sinogram PET, we're also doing dynamic PET, depending on the indication. And practically all patients that undergo PET-MR are clinical patients. Most of them are, of course, in prospective studies, whereas the rest of them is chosen from a list of acute cases. This list is shared with PET-CT, so we would normally look at the cases and then decide who will benefit most from PET-MR compared to PET-CT. So, of course, when we started, beginning of 2014, numbers were rather low. We have seen a steady increase in the patient numbers. We now have a plateau around 300 per quarter, so 100 per month. We don't think that, at least with our present protocols, we can go much lower. So when we started, we actually had to lure the clinicians into sending us patients for the PET-MR because they didn't yet know the technique. But now we already have a 4-week waiting list for PET-MR, so it's well accepted. And in the beginning, like most other centers, we also performed many dual modality studies, so PET-CT and after it PET-MR or the other way around. Of course, that was for quality assurance and also for comparative studies. After a few months, this changed, and now most of the examinations are done as single modality PET-MR studies. So these are the patient numbers from 2015, and it's obvious where the research focus is, I think. On prostate cancer on the one hand, on lymphoma on the other hand. All other indications, while not rare, are less common. Cardiovascular is coming up, so in 2016, in the first quarter, we have seen an increase in those numbers. But clearly these two are number one, and as you can see, most of them are done by PET-MR, only no additional PET-CT anymore. And now let's really look at the workflow. So Munich, if there is just a question in terms of neurology or cardiology from that field, they would just use one bed position, which makes sense because the diseases found in these regions rarely spread to other organs. So the time here for the entire examination is mainly defined by the choice of MR sequences, and in particular in neuro and in cardiac imaging, that can be quite a lot. Now for body oncology, Munich looks at whether or not the patient has had any previous exams. If he already had extensive imaging by CT or by MRI, then they would just focus on one region. If not, they would go to the next bed position, either with the same set of MR sequences or a different set of MR sequences. Now in Vienna, we have a rather basic, fast whole-body protocol where we use 5 minutes per bed position for the PET acquisition, and in that time we obtain, apart from the attenuation correction sequences, T1 Vibe-Dixon sequences in the axial direction, as well as DWI and free breathing, because we really think that DWI often can really add valuable information. And then we would just do a T2 haste coronal, so we have a second imaging plane with no extra PET. Now, if we have the suspicion that there is or if we know that there is a low-grade tumor, we may use a second time point for PET. depends really on the histology. And this is because we know that the low-grade tumors, as was mentioned in the previous talk, often have a prolonged uptake, whereas we see tracer washout in the surrounding tissues. And that's why the lesion-to-background contrast may be improved, leading to higher detection rates. There have been a few papers about that. So in this case here, for instance, that was one of the patients who underwent both PET-CT and PET-MR. And we can see that the lesion seen at the later time point here in PET-MR, which is a mold lymphoma of the stomach, was not at all visible at the regular time point. So here it really made a difference. Now, this is the kind of protocol that is used in most patients. As I mentioned in the beginning, most centers would focus on one region, use an extensive MR protocol there, and then use a basic set of MR sequences for the rest of the body. So in Munich, the whole body scan is performed first, 4 to 5 bed positions, head to pelvis, with just a coronal T1 and an axial T2 sequence. After that, they will focus on the area of interest, for instance, where the primary tumor is located in case of the liver. And the difference is that here they would perform list mode acquisition while doing their extensive set of sequences, including DWI, including dynamic contrast enhanced images. And after that, without simultaneous PET, they would just use an axial wipe for the whole body. The same in the head and neck, just with another set of sequences, no DWI here because there may be artifacts, but basically the same idea, and the same in the pelvis, slightly different protocol, but apart from that, the same mode. So in Vienna, we would use a similar strategy, but sort of the other way around in almost every respect. So we would first obtain the list mode data for the area of interest while doing the indication-specific MR sequences, and we would then do the whole body, but in contrast to Munich, from pelvis to head, whereas Munich does it from head to pelvis. The reason why we do the pelvis first is because, of course, the bladder is filling up with tracer, and we want to avoid effects on the surrounding tissues and lymph nodes in the pelvis. That's why we do the pelvis first. We might do MR spectroscopy if that for some reason is of interest or relevant for studies. Now, there is often the debate whether or not for PET MRI you would need contrast material. You would need DWI because actually PET gives you a great deal of information anyhow. I'll show you a few cases why we think that this is feasible. So in this case, for instance, a patient with a neuroendocrine tumor in the small bowel, which was resected. This is a follow-up, and on the PET-CT, and the CT for that matter, you don't really see anything. Now then we performed the PET-MR, and on the DWI we saw this small lesion here, small as it is, but it shows a diffusion restriction. You can also see this on the gadoxetate enhanced imaging. So this is the 20-minute hepatocyte-specific phase, a very, very small lesion here. Interestingly, on the PET of the PET-MR, you see a tracer uptake here. And why is that? Well, if you compare the two, obviously because of the later time point. So also here the second time point, which we didn't really expect, made a difference. Another case, a patient with GIST follow-up after Gleevec therapy, which is pretty standard in these patients. So you see this residual lesion here, which is obviously not FDG avid anymore. The contrast-enhanced image doesn't really add much to it. But what do we see on DWI? So if you look at the capsule here, there seems to be some mild diffusion restriction maybe. It's unclear whether or not this is really of any value in this case. But what we do see is the lesion here in the kidney. Strong diffusion restriction. Let's go back. What did we see here? There may be some mild contrast enhancement here compared to the normal cyst here on the other side. And there seems to be a mild tracer uptake, which you can also see on the PET image here. Now, of course, you don't really, we missed it on the PET, because of course, due to the uptake in the urinary system, due to the excretion of FDG, we would have thought that this was just urine, but it wasn't, and turned out to be a renal cell carcinoma. And one final case, so this is a patient who had difficulty to urinate. You see this lesion here, or maybe it's just the prostate. It really does have the same signal intensity as the prostate on the T2, but you see this thin rim here, which is kind of strange. And then on the DWI, you saw that it's obviously separate and highly diffusion restricted. And this turned out to be a mold lymphoma. As you've heard in the previous talk, the low-grade lymphomas, the slowly growing lymphomas, can have a very limited FDG avidity, if any. So let's go back to the protocols. For prostate, which I mentioned is a major topic for PET-MR, Munich would use the same approach as in the other tumors, so focus on the prostate with a 50-minute list mode data acquisition for PET, and a multiparametric MR protocol, quite extensive, with dynamic contrast enhanced imaging and DWI and everything, and high resolution sequences. Now the question is, should we always do this? Should this always be done? Because, I mean, in the end, PET-MR is not PET-CT. Should maybe PET-MR focus just on one region? I mean, that's definitely a subject for debate. And in Munich, for biopsy targeting, they would just do the regional acquisition in the pelvis at the site of the cancer. And these are images from their institution. You can see how well the different parameters work together. The cancer here with the diffusion restriction and the PSMA uptake, which corresponds quite well to histology. So I'll just talk briefly about cardiac imaging and generally dual tracer imaging, because we also do that in Vienna. Munich does not do dual tracer imaging. So for cardiac imaging, for instance, we would inject 2 different tracers after another. First, the ammonium for the perfusion information, and then FDG for viability information. So the ammonium is injected when the patient is already on the table, already in the scanner. And then after 20 minutes, we would inject FDG. I mean, do you think that this is a problem for the PET acquisition because the two would interfere with each other? Obviously not in this case, because 13N has a very short half-life. So in particular, in the later phase of the FDG list mode data acquisition, there is hardly any effect of the first tracer. And we would perform a full set of MR sequences, cinema sequences, STIR for edema, and then together with the FDG, contrast medium with perfusion, early and late enhancement, as well as T1 mapping. And this is just an example, a patient with ischemic cardiomyopathy. The question, as always, is, should revascularization be performed in this patient, and what can we see? We have the late enhancement sequence here, which nicely shows the infarct. There is no uptake on FDG, no ammonium uptake here, so this is obviously a match between the two techniques. So this is scar tissue, this is dead myocardium, and revascularization makes no sense. Now the opposite case is here. Another patient, you see the thinned myocardium, you see no uptake on NH3, but there is still some uptake on FDG. So this is not all dead tissue. Here revascularization makes sense. And there is another application for dual tracer that we're using in Vienna, rarely, but we are using it for HCC. As you probably know, there is no real HCC-specific tracer, at least not in clinical practice, at least not established. So that's why we would use FDG and fluorocholine, also inject them after the other. The problem here is just that, of course, both are based on F18. So what do? Here we have to use a time activity curve based separation of FDG and FMC data, so software based. Otherwise the two would interfere. And an example here, patient with hepatitis C cirrhosis and elevated AFP. Of course, that's that points toward HCC. In the arterial phase, we see that this is a hypervascular lesion with, in the venous phase, you see that the contrast medium has gone. So obviously, this is typical of HCC. Now, what do you see on the FDG PET? Nothing. No increased uptake. Whereas on the FMC, you see a strong tracer uptake. And if you look at the literature, you will see that the well-differentiated forms of HCC show an uptake of choline, whereas the undifferentiated forms show an uptake of FDG. I mean, it's not black and white, but an overlap, of course. But in general, and this turned out to be a well-differentiated HCC, just as predicted by the dual tracer PET. So this is one of the things that PET-MR can, of course, be used for tissue characterization, using multiparametric MRI, using dual tracer PET. That's actually what we think that PET-MR should be used for. So tissue characterization, better response evaluation. So to sum it up, in terms of scan duration, both Munich and Vienna would not use a time slot of more than 60 minutes, at least not for the majority of patients. In Vienna, we perform dual tracer imaging, which might require up to 80 minutes, though. This is not done in Munich. With regard to the scanning order, Vienna scans the area of interest first and then the whole body, the other way around in Munich. Munich performs most whole body scans head to pelvis, Vienna pelvis to head. That's because of the bladder filling, as I told you. And in both centers, we are seeing an increase in dedicated single region scans. Maybe that's the future of MRI, PET-MRI, maybe it's not. We will find out. In the end, protocols and workflow are always a matter of personal preference. But as you know, many roads lead to Rome. Thank you.